Good evening, everyone. And I know it's been a really long day, mostly transplant, and we're going to be completely shifting gears here to just general nephrology, as I am a general clinical nephrologist. And as Jamil said, these are cases I've collected at the Brigham. Most of them are my own, some of them from my colleagues. But we'll get started. I have nothing to disclose. The first case is one I saw taking care of dialysis patients years ago. A 24-year-old Kuwaiti male, history of chronic kidney disease due to reflux nephropathy from posterior urethral valves. His status post multiple procedures requiring self-catheterization. His valves were first resected at 15 days of age and then revised at 17 years. He progressed to ESRD. He was started on dialysis in Kuwait via an AV fistula, and he came to the Brigham 4 months later for a transplant evaluation. His labs at the Brigham, after missing several days of dialysis while he was traveling, were a BUN of 90, creatinine of 12.7, a bicarb of 12, a calcium of 7.8, phosphate of 6.6, and hemoglobin of 14. His medications included metoprolol, calcium carbonate, sevelamer hydrochloride, iron, darbepoetin, and nifedipine. His dialysis prescription was 3 hours on a 180 dialyzer, pretty standard potassium and calcium, 35 bicarb, and dialysis blood flow of 400. He put out quite a bit of urine, 2 to 3 liters per day, so really didn't need any UF. So his lab trend really showed, his BUN came down nicely with actually getting dialysis. I didn't put the creatinine in there, but same thing happened. He had just missed a few sessions. His phosphorus remained a little bit on the high side, and his bicarb remained quite low. But you can see after dialysis, after a few dialysis sessions, he went up as high as 18, but that was really the highest he had gotten. We did do a post after dialysis one day, and it went up from 18 to 27 on the dialysis machine. His URR was 74%. We tried to increase his time to see what that would do. His URR was basically the same, actually lower at 72%. And his ABG was pretty unremarkable, a little bit of a respiratory alkalosis, probably with a CO2 of 30. So the question here is, what is the most likely reason for his persistent acidosis? Is it inadequate dialysis due to a refusal to dialyze longer than 3¼ hours? Is it an RTA due to reflux nephropathy? Is it dietary indiscretion, as evidenced by persistent hyperphosphatemia? Is it just that the dialysis machine was not adding the bicarbonate correctly? Or is it from the sevelamer hydrochloride decreasing the bicarb? And I'll let everybody vote for what they're thinking. All right. Oops. Stop. Okay. Good. So a little bit divided, but I think most people got the right answer here, which is the RTA due to reflux nephropathy. I can close this out. So just to look at some of the other answers. So inadequate dialysis, and we know his URR was okay. His dialysis was probably adequate. And so and you also should see some other signs of underdialysis. Dietary indiscretion would be unlikely to drive the bicarb that low. That would be pretty hard to do without other things like potassium or phosphorus being extremely elevated. If the dialysis machine had not added the bicarb correctly, then he wouldn't have increased from the 18 to 27 in the setting of post-dialysis. And also usually you would see that in everybody who dialyzed on that machine as opposed to him on multiple machines. And the sevelamer hydrochloride can cause a mild acidosis at doses of about 6,000 milligrams per day, it's been shown. We do use sevelamer carbonate more now, partially for this reason. But I think it would be unlikely to cause this degree of acidosis with him being on just 800 milligrams. So it probably was contributing a little bit, but not significantly. So just to talk a little about reflux in the kidney. So reflux nephropathy develops in 30 to 60% of children with vesiculoureteral reflux. Posterior urethral valves are the most common cause. It actually predominates in girls, but it's more severe in boys. Causes some scar formation in the kidneys, including calcial deformities and thinning of the renal parenchyma. There's some tubulo-interstitial damage with some atrophy, tubular necrosis, mononuclear infiltrate, so quite a bit of damage. And the distal tubular damage seems to come before the glomerular disease. So you'll see in people that have normal creatinines, you still can see this RTA. Children tend to have hypokalemia as well, showing renal potassium wasting, as you'd expect in a distal RTA. But interestingly, this RTA seems to persist for many, many years after treating the obstruction. So you'll see it almost forever. I saw a patient today with obstruction, and she still had an RTA many, many years later. This is kind of a busy slide, but it's just so, in the RTAs, so the patients that had the negative anion gap, the positive anion gap, so were more likely to be the RTAs, their urine pHs were all 5.5s to 6s, and unlike the patients that weren't from an RTA had low anion gaps, as you would expect in the setting of being acidotic, kind of pointing to the fact that this is a distal RTA that's causing the problem. So in this patient, he continued to be quite acidotic on dialysis, to the point where when he had the transplant, they actually did bilateral nephrectomies to control the acidosis. And it did indeed control the acidosis. So I thought was kind of interesting, something we don't really think about in dialysis patients very much, but he was making urine, and that's what happened with him. So the next case is a gentleman I saw in the intensive care unit at the Brigham, a 77-year-old male who's originally from the Azores, past medical history really of just bladder cancer. And 8 months prior to admission, he had developed joint pain and joint swelling and pain, had an ESR of 59. He was started on prednisone for presumptive polymyalgia rheumatica, and his symptoms improved. But then I guess it was about 6 months later, so 2 months prior to admission, he developed anasarca and a rash. He was noted to have 5 grams of proteinuria and a serum albumin of 1.8. A CT was done to rule out malignancy associated with presumed membranous nephropathy, and on the CT, they saw a PE and a left renal vein thrombosis. So at this point, they felt like they couldn't biopsy him because anticoagulation needed to be started immediately, but they increased prednisone to 60 milligrams daily to treat membranous nephropathy. That is not what this talk is about. I know there would be a lot of debate about that particular treatment, but he was started on lisinopril and Coumadin. The labs at that time, he had negative hep serologies, negative anti-DNAs, normal C3 and C4. His SPEP didn't show any monoclonal gammopathy. His capital lambda was normal. So pretty unremarkable. So 2 months later, he presents to the emergency room at the Brigham with severe diarrhea and sepsis. He's found to have esophageal candidiasis, E. coli bacteremia, and enterococcal bacteremia. He had massive anasarca, was normotensive, otherwise fairly unremarkable exam. Just the anasarca was really quite impressive. His serum albumin, which we rarely see in adults, was 0.8 with a creatinine of 0.5. Cholesterol, relatively unremarkable. His UA had 3+ blood, 3+ protein, a protein to creatinine ratio of 5. Urine micro really just had hyaline casts, occasional dysmorphic red blood cells, not overly impressive. Renal ultrasound looked generally normal with 11 centimeter kidneys. And his ANCA and GBM were negative. Rheumatoid factor was less than 11. C3 and C4 were both low at that time, although he was septic. His cryos were negative. Prior to his subsequent death due to overwhelming sepsis, he was also found to have disseminated strongyloides and aspergillosis. So in this sad case, the question here is, what is the most likely cause of the patient's renal presentation? Is it a post-strep GN from an undiagnosed strep infection, AL amyloidosis, strongyloides associated membranous nephropathy, candidiasis in the kidney, or a renal vein thrombosis? And there we go. Okay, let's see here. So yes, so I think most people got this one right here. And I bring up this case less as a diagnostic dilemma and more as something that we really should be aware of, especially in patients who we will immune suppress, either for transplant or for other issues that we're immune suppressing patients for. Because in this case, and I'll show you the biopsy on the autopsy, he had strongyloides-associated membranous nephropathy. Just to quickly go over the other answers, post-strep GN is rarely going to cause a nephrotic syndrome. It's usually nephritic with a rise in creatinine and hypertension, low C3, normal C4, and a self-limited course. AL amyloid would be pretty uncommon without abnormal light chains in the blood. Candidiasis can cause microabscesses in the kidneys, maybe some papillary necrosis, maybe pyelonephritis, but a nephrotic syndrome would be unlikely from the Candida. Renal vein thrombosis, he did have this, but it's thought to be more the consequence of hypercoagulability in the nephrotic syndrome, not the cause of the nephrotic syndrome. Although that's a little bit unknown, but thought to be the case. So just to touch on secondary membranous nephropathies. So the most common causes, I think cancer should definitely be thought about, NSAIDs and other drugs, lupus, hepatitis B and C, but also some chronic infections. So big ones are schistosomiasis, syphilis, strongyloides, malaria. And this is something I had never seen before, disseminated strongyloides, but I know we actually test all our transplant patients before they get transplanted for strongyloides, especially if they're from an endemic area because of this. But often in a patient that has chronic strongyloides but is totally asymptomatic and then becomes immune suppressed. So in this guy, he probably did have PMR, got put on steroids for the PMR, and the strongyloides that he had from the Azores kind of reared its ugly head. It can disseminate to almost any organ. Dissemination to the kidneys usually causes either minimal change disease or membranous nephropathy. There are case reports of improvement in kidney disease with ivermectin to treat the infection. So I suppose if somebody had thought to check strongyloides and treat him with ivermectin, that might have turned things around for him. So this is just a picture of membranous nephropathy here. But you can actually see in this case, and this is, once again, his autopsy, there are actually little strongyloides larvae in the glomeruli. And this is in a peritubular capillary. There's a nice larva as well. Subepithelial deposits that are consistent with a membranous nephropathy. And there actually was lung tissue as well in this patient that had strongyloides in it. So I think the take-home message is here that the patient was likely exposed in the Azores. When he was started on steroids, it disseminated. It worsened when the steroids were increased as the nephrotic syndrome developed. And, so I think just anytime that you're initiating or increasing immune suppression in a patient that might be from an endemic area, you might want to test for an infection like this. So in theory, ivermectin would have been the better treatment here if anyone had known this. So once again, with organ transplant lists and stuff, given that the theme of the day today is transplant, definitely should be thinking about these things. Okay, so this is an out-of-hospital case. This is a patient that was referred to me in renal clinic. And 54-year-old male, MBTA train driver, history of hypertension and hypokalemia with a potassium as low as 2.8 without medications for at least 7 years before coming in. He was noted as his primary care office to have a magnesium level of 1.1. It had never been checked prior. And so he was sent to nephrology clinic for evaluation and management. He was put on magnesium before he was sent to me. His past history, hypertension, hypokalemia, GERD, and epicondylitis. His meds on presentation to renal clinic, he was on magnesium gluconate, 2 grams TID, potassium 60 milliequivalents, so pretty high doses of both, amlodipine 10 milligrams daily, omeprazole 20 milligrams daily, and spironolactone 12.5 milligrams daily. He had 2 alcoholic drinks per week, seemed pretty reliable about that. He has no known history of low potassium or magnesium, although wasn't completely sure of his family history. His primary had sent him for a 24-hour urine, although had not sent off magnesium. And really everything was fairly normal, including the potassium, despite the low potassium, except for his calcium level of 11 milligrams. So that was pretty low. But everything else was normal. His creatinine was pretty much as expected for his body habitus. So I think this probably was a real collection. So when I saw him in clinic, his magnesium level was 1.6. That was once again on these medications to bring it up. Potassium was 3.5. Bicarb level was 25. Phosphate was 2.7. Calcium 8.7 and creatinine 0.8. His PTH level was 31. Transtubular potassium gradient, which I realize is debatable whether it really is helpful, but it was a little bit elevated at 9.7. Aldosterone was undetectable, renin level was undetectable, and his spot urine magnesium was undetectable. So the question here is, what is the most likely reason for the hypomagnesemia and hypokalemia? Is it omeprazole, Gittleman syndrome, an RTA, amlodipine, or Barter's syndrome? All right. So I think every year when I do this, it's pretty much tied between A and B like this. And the correct answer is actually the omeprazole, and we'll go through why. So Gittleman syndrome absolutely will cause a low magnesium and a low potassium, but the mechanism for this is through magnesium wasting, and his urine magnesium was completely undetectable, which makes this less likely. And the other thing is that his the urine calcium is low, which is consistent. But yeah, the big clue that this wasn't the Gittleman syndrome is just the magnesium level, that he should have had magnesium in the urine. RTA, the serum bicarb is normal. He really didn't have an RTA, and this doesn't cause low magnesium. Amlodipine is also not a cause of these findings. Barter's syndrome should present with high urine calcium, high urine magnesium. It also usually presents in childhood and almost always with a family history, so less likely to be Barter's. So PPI-induced hypomagnesemia was first reported in 2006 in the New England Journal. Seen in patients usually who have greater than 1 year of proton pump inhibitor intake, although it can be 8 to 10 years after, it can be quite a long time after. Seems to be related to any and all PPIs, does not seem to be dose related, so not the kind of thing where you can just taper them onto a lower dose and it goes away. It's often also associated with hypocalcemia and an inappropriately low PTH. So this is a little bit far away, but this is from the New England Journal article, and you can see this bottom line here is magnesium levels. The top line is calcium levels. So over here, you can see omeprazole was stopped right in here, and omeprazole is resumed here. And you can see the magnesium level going up, and this is the urinary magnesium as well. So the magnesium level goes up, which is the gold line, and then this spike right here is the urine magnesium. So basically all of a sudden there is magnesium to be excreted by the urine. And then the omeprazole is resumed and it goes right back down. And then it's changed to esomeprazole and it goes back up. And then the esomeprazole is stopped and it reverses. So kind of showing that it's both of these medications, and that with acutely stopping it really quite quickly, these levels will change. So why does this happen? The low urine magnesium levels certainly suggest that it's due to GI loss from poor absorption. Anytime you see somebody with low magnesium, we think about GI versus renal. Magnesium is absorbed both actively and passively in the GI tract. It can be partially corrected by high dose supplementation, so it suggests that maybe passive transport is still happening. So you give lots of magnesium and it still is passively absorbed. So probably there's some sort of inhibition of active magnesium transport. Potential mechanisms of the potassium, that probably is renal wasting. And in this gentleman, despite the low potassium, his urine potassium was in the normal range. It was not low, which is abnormally high. TTKG is often high in these patients. Aldosterone is often low, so it's not aldosterone mediated. So basically, in general, we often think of potassium and magnesium going together, and normal magnesium levels are believed to inhibit the ROMK channel, the renal outer medullary potassium channel. So this channel is an ATP-dependent potassium channel that will secrete potassium in the thickest ending limb. So low serum magnesium levels kind of relieve this inhibition and are going to increase secretion. So if there's magnesium there, it inhibits that channel. Potassium is not secreted. You take the magnesium away and you increase potassium secretion. And that's thought to be the mechanism for why low magnesium causes low potassium. So why the calcium in PTH? And this is something I was definitely less familiar with until I started looking into this. Low magnesium is known to suppress PTH secretion. And then parenteral magnesium administration will actually raise PTH levels. So a lot of times in low magnesium, you'll see low levels. It also causes resistance of the bone to PTH. Usually this is seen with magnesium levels less than 1. In our gentleman, his levels were not less than 1, but his PTH was a little bit on the low side. And it would explain the serum and urinary calcium to see a little bit of this. So the most pronounced things you'd see with the PPI are the magnesium level and sometimes the potassium level, but you will sometimes see some changes in calcium as well. And I will just say with him, we stopped the omeprazole, put him on an H2 blocker, and quite quickly after this happened, we were able to wean him off a lot of his potassium and magnesium. And then he actually stopped seeing me, but I looked him up a few years later, and I think he was something like 20 milliequivalents of potassium and no spironolactone, no magnesium, just from staying off the proton pump inhibitor. So it can be a pretty impressive thing. It's obviously a lot tougher when the patients need to stay on the proton pump inhibitors. This gentleman just had GERD and was able to be switched, but we know that's not the case with every patient. So the next case here is the only one in this group that was actually not my patient, but I thought it was an interesting case. A 67-year-old female with a GI stromal tumor, status post-imatinib treatment, has hypertension and diabetes. She's on insulin. Hospitalized for low back pain resistant to naproxen, and her serum sodium was found to be 114. They presume this was SIADH due to NSAIDs and pain. They fluid restricted her. The NSAIDs were stopped. Sodium went up a little bit to 124, and they discharged her. She was readmitted 3 weeks later, similarly for pain, and her admission chemistries, her sodium was 120, potassium 2.9, bicarb was 87. I'm sorry, bicarb was 37, I think, chloride 87. Otherwise pretty unremarkable. Her albumin was low. Her bili was 19.5 total and 13.6 direct bili. ALT and AST were up, alk-phos was up. So pretty significant liver dysfunction here. Her blood pressure was 74/50, which improved to 120/77 with IV fluids. She had dry mucous membrane. She looked pretty dry. Her current medication, she was on famotidine, potassium, glargine insulin, vitamins, Fosnac, Ursodiol, and oxycodone. So her serum sodiums, and you can see when her GI stromal tumor was diagnosed, she had a serum sodium of 137, so on the lower end of normal, but normal. After she stopped imatinib, it was 130. As an outpatient, it was 126. Before this, when we looked back in her chart, she was hospitalized for pain, and then after fluid restriction, and then on her next hospitalization, it went back down. So it seemed like it was pretty persistently low, maybe a little bit responsive to measures for SIADH. Here we have her serum osmolarities, pretty normal. Urine sodiums, pretty normal as well, 60s, 90s, and then 146 after 1.5 liters of normal saline. Urine osmolarity, pretty normal as well. So what is the reason for this patient's hyponatremia? Is it a combination of liver disease and dehydration affecting intravascular volume? SIADH due to the oxycodone and back pain? Hyperglycemia causing sodium dilution? Pseudohyponatremia or primary polydipsia? All right. So yeah, I think there was a little bit of thought of SIADH and liver disease in here. Most people thinking pseudohyponatremia. And there probably was a little bit of contribution of the SIADH and the liver disease, and that's why she went up and down so much. But I think the main thing pointing towards the pseudohyponatremia was the normal serum osmolarity. So when someone has a normal serum osmolarity, which hers was every time it's checked, despite the low serum sodium, there has to be some degree of pseudohyponatremia. Volume depletion in liver disease also should have a low urine sodium. So I think in patients we see with hyponatremia and liver disease, the urine sodium is almost always undetectable. In SIADH, the urine sodium and osms were very consistent, but the serum osmolarity should be low. Hyperglycemia, I mean, she has a diabetes history, but her blood sugar was pretty normal, so it shouldn't cause this, although it can cause pseudohyponatremia. It also usually causes a high serum osmolarity. And primary polydipsia, you should have a low urine osmolarity. So pseudohyponatremia, basically artificially low plasma sodium with a normal serum osmolarity. Potential causes, hyperlipidemia, hyperproteinemia, irrigation solutions like glycine and sorbitol, procedures where they give some of these solutions, TURP, hysteroscopy, laparoscopies. And basically the reason it happens, so in normal serum is basically about 93% water and 17% fat and proteins. So sodium concentration really, if you think of a normal saline, physiologically important serum water is 154. But since 7% of that is fat and proteins, and I'll show you the way that we measure it in terms of dilution, the measured serum sodium is basically 142. So if you have a case of abnormal serum where it's 20% fat and proteins per se, you basically do the same measurement and you're going to get 123, even though the sodium is really about the same. And so when we measure sodium, there's indirect with dilution and then there's direct. And basically the way we do this is, so you can see on the left, there's normal, and over here, there's increased fraction of the solid state. So here, you're going to take your normal where you've got, this isn't really 93% and 7%, but I think just to make a point, and you see this particles, and you dilute it by doubling the amount, and the particles are going to decrease the concentration. Here, you've got the same amount of solution, but you've got less particles in that solution because you've just got less of the serum state, and then you are going to dilute it, and you're going to get a much, much lower concentration for the same dilution. So if you do direct potentiometry, which is basically looking at it directly instead of this dilution method, it measures the electrical potential across a sodium selective membrane immersed in the serum sample. The electrical potential is a function of the sodium activity in the sample. And for the direct reading, it's an undiluted sample, although there are ways to apply it to a diluted sample. This is what they do with blood gases. So sometimes if you have a patient where you're not sure if it's a real serum sodium, you can send it on a blood gas and you should get a direct reading as opposed to this diluted reading. So why did this happen in this patient? And once they realized, I think they consulted the renal team, realized this was pseudohyponatremia, and a lipid panel was checked. And the total cholesterol was 1,800 with a triglyceride level of 945 and a direct LDL of 1760. Lipid electrophoresis was done, and there was a band of unknown significance between LDL and VLDL, which was likely something called Lipoprotein X, which I had never heard of before this case. So what is lipoprotein X? It is reflux of unesterified cholesterol and phospholipids into the circulation, usually in the setting of cholestasis, which she had. But these particles are not soluble in water, so will increase the solid fraction of the plasma, and it can cause lab abnormalities, but doesn't seem to have pathologic consequences. So in this case, the patient got imatinib. It caused cholestasis, which we could see from her liver abnormalities, which caused lipoprotein X. And then because of this, in the setting of the type of measurement that was done on the sodium, she developed pseudohyponatremia. Okay, so this is the last case. It's a patient I've been following for years in clinic. A 68-year-old guy, baseline creatinine was 1.1. And he was referred to the renal clinic for a creatinine that went up to 1.5 with unclear reasons. We did a renal ultrasound and it showed nephrocalcinosis. And interestingly, he had had a CT 3 years earlier and there was really no calcium deposition. So this seemed to be new. His past medical history, he had GERD, he had small lymphocytic lymphoma, and he had had a melanoma removed, although that seemed to be removed and cured. His medications, he was on aspirin, he was on calcium and vitamin D at the time, multivitamins, fish oil, and omeprazole. His family history was really only consistent with vascular disease. He didn't have any family history of nephrocalcinosis, kidney stones, anything like that. We did a 24-hour urine as a litholink on him, and the most notable thing here, other than kind of mildly low urine volumes at 1.6 liters, his calcium level, the first time I did it was 521, and otherwise in the 300s. And in most people, normal urine calcium should be under 200 in women, under 250 in men. So this was quite high. One of the days he had a high urine sodium, and so in the loop of Henle, you can get a paracellular drag of calcium, and that will increase the calcium. But the other 2 days, it really wasn't overly high, so that was probably not the major reason. His labs were pretty unremarkable, other than the creatinine was now 1.6. His calcium was 10.5, so borderline high. His 25 vitamin D level was normal at 51. And his 125 vitamin D level was at 122, so kind of double the upper range of what we consider normal. So the question here is, what is the most likely primary cause of the nephrocalcinosis? Is it lymphoma, sarcoid, low fluid intake, high sodium intake, or genetic factors? Okay, so we're having the same debate here that we had, and we actually had to send him to sarcoid clinic to get his lymphoma doctor to treat his lymphoma, because his lymphoma doctor thought it was sarcoid. But it ended up being the lymphoma. And just, the slide might be a little hard to see from here, but this is from up to date. So you can, hypercalcemia and malignancies. So we know there's a lot of ways that whenever you see a really high calcium in somebody, you start to think about malignancies. There's ones that cause PTH-related protein, which are a lot, squamous cell carcinomas, bladder cancers, breast cancers, ovarian cancers. A lot of cancers will cause that. Osteolytic metastases, so myeloma or breast cancer, lymphoma can also cause that. 125 vitamin D associated is usually with lymphomas, but sometimes also ovarian dysgerminomas, but mostly lymphomas for that. And then some cancers will cause some ectopic PTH secretion. So lots of reasons why a cancer can cause hypercalcemia. So why the 125 vitamin D in lymphoma? So normally, the kidney proximal tubule makes 1-alpha hydroxylase, which converts 25 vitamin D to 125 vitamin D. In this case, there's regulation by PTH and FGF23. So calcium goes high and it's regulated and less conversion. In some lymphomas, there's malignant lymphocytes or macrophages can actually cause PTH independent conversion to 125 vitamin D. So even with PTH suppression, it's still happening. And just somewhat of a reminder here in terms of the vitamin D metabolism. So get from sunlight, from cholecalciferol, from vitamin D2 supplements, get vitamin D. And then renally, this can be converted to 125 vitamin D, but there's also this non-renal production of 125 vitamin D. That's much less. You see the thick line here and the thin line here. It's much less. Macrophages, prostate, colon, breast, lung, all do a little bit. But in the setting of something like a lymphoma, this can be really revved up, and it can cause a lot more of it. And other places that have 1-alpha hydroxylase enzymes. So the renal proximal tubule is the main one, but also a little bit in things like the skin, the GI tract, the vasculature, mammary epithelial cells, osteoblasts and osteoclasts. Some of these other disorders, you can get high calciums as well due to this conversion. Pretty commonly, so sarcoid granulomatous diseases, sarcoid and tuberculosis are probably the two most common. I think I saw a fellow presentation a few years back about BCG associated and somebody being treated for bladder cancer, ended up with hypercalcemia. Some fungal infections that can cause, anything that can cause granulomatous diseases can cause an activation of 125 vitamin D. But basically activated macrophages in the lungs and lymph nodes produce this 1-alpha hydroxylase. So that's the mechanism in something like sarcoid. So this patient, it really actually took probably a year. We really thought it was the lymphoma, and we sent him to sarcoid clinic because his lymphoma doctor really felt very strongly that it was not the lymphoma. He didn't have any other indication to treat this lymphoma that was indolent. And so we sent him to sarcoid clinic. The sarcoid team did a full workup, really felt like this was not sarcoid, and that he should be treated for lymphoma. He was started on ibrutinib for lymphoma, and his creatinine baseline went back down to 1.1 to 1.3. His 125 vitamin D level increased to 32. And we did a few other litholink analyses. He was pretty detailed and determined and really wanted to check and make sure that his nephrocalcinosis was not coming back. And this is pretty dramatic. So this is the calcium pre-treatment and this is the calcium post-treatment. And the only change other than taking him off is kind of calcium and vitamin D supplements, but that was done here after the first two, not up here, was the ibrutinib. And his creatinines remain normal since then, and and he hasn't had any issues. He never had issues with kidney stones, but his urine calcium has remained low. So just one last quick thing here, since this is a talk about bored zebras. So a final must-know zebra. What disease presents with zebra bodies? Fabry's, immunotactoid GN, amyloidosis, Alport syndrome, or Balkan nephropathy? Great. So yeah, this was really just thrown in for fun, but absolutely. So Fabry's disease presents with zebra bodies. So lysosomes filled with, I can barely pronounce this, but trihexosylceramide due to a defect in lysosomal alpha-galactosidase. Vacuolated visceral epithelial cells. These vacuoles stain with toluidine blue and the semi-thin sections taken for electron microscopy. And that's it. Thank you all.